It's a great pleasure having Billy here with us. Obviously, I think this contribution that Billy and Fontan gave us surgeons was incredible, and for all the patients. We just have a little gift for Billy, so that just to congratulate him and sort of commemorate this first international symposium here in Pittsburgh, and we would love if Billy can come up here and just take a little present that we have for you, okay?
Excellent. Thank you so much, Dr. Kreutzer. Our next session is Living with Fontan-Kreutzer Circulation. It's my real pleasure to introduce Dr. Lorenzi. Dr. Lorenzi has a PhD in psychology from the prestigious Duquesne University here in Pittsburgh and is the director of the Cardiac Neurodevelopmental Program here in Pittsburgh. She follows kids and families with single ventricle physiology from before birth till after the Fontan-Kreutzer procedure, and she will be talking about resilience and optimizing mental health post-Fontan-Kreutzer procedure. Thank you.
Thank you so much for the kind introduction and for the opportunity to speak today. Amazing resilience and a high quality of life are certainly described by many individuals with congenital heart disease living with Fontan physiology. However, it is also known that significant psychological challenges do exist across the lifespan, with higher rates of emotional, behavioral, and social difficulties in this patient population. And my hope today in our discussion is to encourage not only an increased awareness of the challenges to maintaining psychological well-being faced by patients and their families, but also to speak to the importance of the implementation of strategies to prevent and alleviate distress and promote resilience through consistent and integrated mental health care. There's an increasing appreciation of how psychological health can contribute to cardiovascular health and reduction of cardiovascular risk. In 2021, the American Heart Association issued a scientific statement of these relationships and encouraged greater screening, evaluation, and treatment of psychological health. I'm sorry, sir. There's substantial literature in the adult world connecting mental health and heart health. In adults with congenital heart disease, those with depression have higher inflammatory biomarkers, higher rates of heart failure, and ultimately increased risks of mortality. Just in the CVD, mortality risk with diagnoses of anxiety actually increases by close to 40%. The mind-heart-body connection has been further explored as psychological health can adversely and immediately affect the heart, but the broader, longer-term relationship where psychological health can also positively, but also negatively affect various aspects of cardiac health continues to be unveiled, especially within this patient population. With an established understanding of the challenges that these patients and families encounter to maintain their psychological well-being across their continuum of care, we must now engage in the implementation of these strategies to prevent mental health challenges, as I mentioned. There are many contributing domains to these psychological outcomes and well-being, and these are interrelated and cumulative and certainly longitudinal in their impact. We better understand that preoperative risk factors, genetics, socioeconomic status, low birth weight, gestational age, brain dysmaturation, all of these are contributing along with cumulative morbidities and particularly parental mental health. These are more strongly associated with adverse psychological outcomes, more so than the intraoperative support techniques that maybe were previously more attributed. But there are lifelong consequences to the adversity and toxic stress that are often assumed by these patients and their families, and really generating a multidisciplinary and preventative model to support is crucial for positive outcomes. The relationship and prevalence of neurodevelopmental delay and disability in this patient population is certainly well established, and the link between psychological and neurodevelopmental outcomes is clear. This was well established in the Boston circulatory arrest study with RTJ patients, noting that neurodevelopmental difficulties in school age, notably with attention, and adolescence in the realms of executive functioning, and also social development or social cognition, were associated with later poor psychosocial health outcomes. Specifically, the cognitive functioning at age 8 was predictive of the psychosocial health at age 16, with attention difficulties being one of the strongest predictors. But this just speaks to the fact that neurodevelopmental impairments can be critical targets for our interventions to reduce longer-term psychosocial adversity. The psychosocial challenges that our patients face certainly morph across the lifespan, beginning in infancy and moving throughout the time periods. There are high levels of hypersensitivity to stimuli, neurobehavioral and regulatory difficulties due to so many factors of the extended hospitalizations and stressors to caregivers and patients in this kind of critical developmental period. And as we move into childhood, this can morph into more emotional and behavioral dysregulation, leading to maybe more diagnostic findings. So there are certainly heightened rates of internalizing disorders, namely anxiety, at almost sometimes upwards of 25%, and externalizing difficulties as well. We all know the heightened risks for ADHD. Sometimes in various studies of single ventricles ranging between 5 and even 24% prevalence rates. The heightened rates of autism spectrum disorder diagnoses with sometimes 4 to 6 times increased prevalence rates. There are certainly parental reports of some difficult to manage behaviors and heightened aggression, opposition, or even defiance. And it's a critical time for families as they're kind of balancing the need for supports while fostering autonomy of their medically complex child. Moving into adolescence in this period of independence and fostering autonomy and identity formation and the goals of socialization and peer relationships, we do tend to see heightened rates of depressive symptoms, and this is certainly linked with quality of life. There are so many contributors to mental health in this time period, but academic difficulties related to neurodevelopmental implications or learning disabilities, health-related school absenteeism, the physical limitations or activity restrictions. I swear that's probably what I speak about the most with my patients. Social anxiety or body image difficulties, parental overprotection that can linger from that infancy period, and also an ambivalence of discussing their CHD diagnosis with peers and how to kind of foster that confidence despite their medical challenges. And that transition period is also a great period for intervention as well from a mental health perspective, with this increased health responsibility and the transition sometimes from pediatric to adult congenital heart care. The psychological distress that can sometimes be linked to poor treatment adherence is certainly an area for intervention, as this is a critical time point to assure solid practices around their independence in medical care. And moving into adulthood, we again see these heightened rates of various psychiatric diagnoses, depressive symptoms, really range the literature for mental health outcomes as you know, certainly is still broadening in this patient population. So the rates that are found are certainly expansive. However, depressive symptoms may be found in upwards of 36% of patients, anxiety from 34 to 42%. The highest rates of anxiety are more so in the realms of social anxiety and separation anxiety, potentially related to some of those kind of early experiences our patients go through in terms of separation from caregivers. Other psychiatric disorders, including various potentially heightened rates of schizophrenia, are all further being investigated. But some of the risk factors certainly include poor neurocognitive functioning, loneliness, limited social support, poor perceived health status, or sedentary behavior, all of which are great areas for intervention from a mental health perspective. And we can't speak to the mental health of the patients without thinking of the mental health of the parents and the caregivers. We recognize that compromised parental mental health can lead to long-term cognitive, health-related, or behavioral problems in our patients, and the challenges that caregivers face from a psychological perspective are broad, notably post-traumatic stress and other acute stress disorders. This must be monitored for a variety of reasons. The prevalence, the critical time period during the time of early surgical intervention, when the development of attachment relationships and that parent-infant-child relationship is really broadening, and the cascading effects that this can have on families and longer-term outcomes is certainly a growing area of interest. In a review of 30 studies of the mental health of parents, and this literature is actually more broad than that of the patients, there is an understanding that the elevated risk is broad. So we're seeing 30% of symptoms consistent with PTSD. That's 3 to 4 times that of the general population in parents of children with critical congenital heart disease. 80% of parents are presenting with clinically significant symptoms of trauma, 25 to 50 with clinically elevated symptoms of depression or anxiety, and 30 to 80% of parents experiencing severe or psychological distress. A 2017 article from Boston with a cohort of 156 adolescents with single ventricle CHD undergoing the Fontan procedure was, I think, a really strong window into the implications in this patient population, as it included clinician-rated psychiatric interviews, not just parental or self-report ratings or review of depression showing in the medical record. With this particular study, there were 5 times higher rates of lifetime anxiety diagnoses, 6 times rates of lifetime ADHD diagnoses, and 65% of youth actually had some realm of a psychiatric diagnosis. So much higher numbers than we had seen before. And beyond these numbers themselves, many more will experience psychosocial stress that may not necessitate a formal diagnosis, but could certainly benefit from additional mental health support. A 2022 meta-analysis of all of this psychological functioning work did find variation in a review of children 0 to 25. There were 23 studies on anxiety, 24 on depression, and 22 on externalizing behaviors, namely ADHD, in our single ventricle population. And the cumulative data does show that, or does suggest that these diagnoses are notable risk factors for patients from a mental health perspective. So what can we do? Mental health interventions are certainly warranted, and especially when emotional distress is impeding daily functioning or impacting quality of life, and certainly when it's impactful on medical care. The mental health professional availability definitely differs across institutions and certainly across communities. But we are seeing in the literature and through some of our collaborative networks and work that there's an increasing understanding that families and patients are seeking mental health care that is specific to that of their cardiac diagnosis. Having that understanding can certainly enhance treatment and hopefully improve outcomes. So it's a continued goal to integrate mental health care into the cardiac home. So with the focus of embedding providers and psychologists into our cardiac centers, we have the opportunity to normalize emotional reactions to health difficulties and challenges. We can reduce stigma of accessing mental health care. We can improve access to targeted and specialized evidence-based interventions, improve equality in access, which is always an incredibly major goal, foster this interdisciplinary approach. There's so much overlap in the presentation of various mental health diagnoses and cardiac symptoms, so traversing that is incredibly important with full collaboration between the medical and mental health providers. And then fostering just psychologically informed care is always an important goal. There are only actually 2 studies thus far on the specific impacts of certain psychotherapeutic interventions, one with parents and one with adolescents in a group domain. There is certainly a lot still to be learned about the specific interventions and what might be most effective in this patient population. However, having kind of targeted and embedded therapists that understand the cardiac population and can use a realm of different interventions dependent on the presenting problem is certainly going to meet the most needs at this time. And of course, also psychopharmacology, it can be so assistive to have kind of embedded psychiatric support within an institution to have that full communication between the cardiac and psychology and psychiatric providers to optimize the implementation of psychotropic medications. There's many areas for growth in this domain as we continue to work with these patients as they move across the lifespan. But targeting psychological care and outcomes is just such an essential component of caring for our patients with congenital heart disease, specifically those with single ventricles after undergoing the Fontan-Kreutzer procedure. And increasing screening and early identification of psychological need to offer preventative care and catch these difficulties early is certainly going to improve outcomes. We always aim to increase access to evidence-based, individualized, culturally sensitive, and accessible mental health care, which is a challenge, as we've all seen, especially in the last years in the COVID pandemic, as behavioral health resources have been difficult to come by. But that's a constant goal. And sharing of resources and collaborative initiatives throughout our many networks, including the Fontan Network, is going to be really helpful for moving this very targeted service forward. As we kind of unite our psychosocial support teams within heart centers and broaden relationships within our institutions, but also with schools, with communities, with families, we're going to allow for mental health to have a growing seat at the table, which I think is really critical as we continue to improve outcomes in this really amazing patient population. So, thank you.